Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
warahmatullahi ta'ala wabarakatuhu.
Bismillahirrahmanirrahim. Walhamdulillah wa syukurillah. Wassalatu wassalamu ala rasulillah. La hawla wa la quwwata illa billah. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Good afternoon to our honorable nurses from Al-Nur Specialist Hospital. First and foremost, I would like to thank everyone in this hall for allocating your time for about 40 minutes on your busy schedule to attend this function. So from the bottom of my heart and all those involved in organizing this function, thank you very much.
Thank you.
Before we move on, let me introduce myself. My name is Rina Lestari. I'm working as clinical resource nurse in nursing service department and as nursing director secretary. I am also one of the ACLS instructor in Al-Nur Training Center. I'd like to ask if all of you are the BLS provider certified.
Yes.
Okay, so inshallah it will make it easy for us. Today I'm going to share with you about the latest update from American Heart Association. For 30-minute presentation, I'll open all the content of the BLS updates for adult and opioid life-threatening new algorithm in 2015, and then move to pediatric BLS. And at the end of the session, there will be question and answer. And I already prepared a little bit remembrance for all of you, those who can answer the question. Okay, so everybody ready?
Yes.
Ready.
Okay,
We're
so
ready.
let's start then.
Okay.
As we know that American Heart Association kept updating us every 5 years, the evidence-based practice medicine to help all of us as healthcare practitioners to achieve the best outcome on saving a life. First, we'll open about BLS 2015 science updates for adults. The first content is about immediate recognition and activation of emergency response system. And then we'll move to emphasize on chest compression, shock first versus CPR first, chest compression rate, depth, and chest recoil. And also, we will discuss about minimize interruption in chest compression, ventilation during CPR with an advanced airway for all ages. American Heart Association separate chain of survival has been recommended that identify the different pathways of care for patients who experience cardiac arrest in the hospital, or we call it IHCA, intra-hospital cardiac arrest, and also outside hospital cardiac arrest. The elements of structure and process that are required before the convergence are very different from two settings. Patients who have an outside hospital cardiac arrest depend on their community for support. The rescue must recognize the arrest. They will recognize the arrest and then immediately call for help, initiate the CPR and provide the fibrillation, then waiting until the emergency medical service, who already trained well, will help them and will transport the patient to emergency department, and they will either move to cardiac catheterization or ICU. The second update, we have the immediate recognition and activation of emergency response system. As we know already that the first thing to do when you saw a patient arrested, we have to, very good, check for the responsiveness, right? In the BLS, 1, 2, 3, 4. First, check responsiveness. Second, very good, yes, and then for help, and check for pulse. That is our 1, 2, 3, 4 in the other. Now here, in the 2015 guideline, we are merging it, okay? From checking pulse and breathing, we are doing it simultaneously. So we save a time for around 10 seconds. After you assess the breathing and pulse simultaneously, there is no pulse, no breathing, immediately you call for help, or you can call for help first and then you can check for pulse and breathing at the same time. Different with the first 2010 guidelines. Remember, first, hey, are you okay? Then you will see the chest movement, if there is any chest raise or not. When you are sure there is no chest rise, you are calling for help, please immediate call for EMS and bring an AED. Remember about that? And you will go back to the patient to check for the pulse. How many seconds you need for that? At least 20 seconds. 10 seconds, less than 10 seconds for checking the breath and less than 10 seconds for checking the pulse. In 2015, simultaneous breathing and pulse check in less than 10 seconds. You are doing it together while checking for the pulse. At the same time, you will observe for the chest rate. The third update is shock first versus CPR first. In 2010, for an unwitnessed arrest, 1/2 to 3 minutes of CPR may be considered before attempted defibrillation. They did survey, they studied it, that either there's difference between you are providing early defibrillation or you are giving 1/3, 1/2 to 3 minutes of CPR, there's no change. Okay? So rather than wasting money for doing CPR first, once the AED is ready, you can immediately attempt the defibrillation. Of course, while applying the pads into the chest of the patient, you can continue CPR at the same time. So, shock first rather than CPR first. But once the AED is ready. How if the AED is not ready? Error. For example, once you turn on, it's saying, apply the pads. Apply the pads. Apply the pads. What you will do? Are you going to search new AED? No, you have to immediately start CPR. Emphasize on chest compression. It is very important to tailor the sequence of compression to the most likely cause of arrest and adjust the circumstances. As we know already, the high quality CPR is providing adequate ventilation. So you cannot separate between ventilation and compression. The next update is about chest compression rate. In 2010, we are delivering chest compression at rate of at least 100 per minute. Still remember about that? At least 100 per minute. And in 2015, now in 2015, we can deliver chest compression still from 100, but they added the recommendation maximum number, which is 120 per minute. Why we are not allowed to give more than 120 per minute? Possibility, once you give more than, means very fast, more than 120, usually you cannot reach the depth of what you will target. Okay, so much better you are using 100 to 120, not too slow and not too fast. It's enough to push the blood flow and coronary perfusion to the brain. The chest compression F in the adult sternum should be depressed at least 2 inches in 2010 guidelines. In 2015, they recommended again for the maximum number, which is you cannot push the depth more than 6 centimeters. There are very, very few results that even though that is not life-threatening, but there's an injury. Okay, once you push for more than 6 centimeter. Emphasize on chest compression depth. We know that it is really difficult to judge the compression depth without use of feedback device. Our training center, we have a mannequin that once you press it and it will give you sound of click, means you reach 2 inches. Okay? If you didn't hear the sound of click, means still you need to push harder. But in the reality, you have to imagine that this is already 2 centimeter. Chest compression depth is more often too shallow than too deep most of the time. Anyhow, and compression depth approximately 2 inches is associated with a greater likelihood of favorable outcomes compared with shallower compression. Research suggests potential injury when compression are too deep, greater than 6 centimeter or 2.4 inches. The next update is about the chest recoil. 2015 guideline, we are emphasizing that still you have to let the chest of patient during compression to fully recoil, means to return back to the same position during the compensation of CPR. But they added that you have to avoid leaning on the chest between compression to allow full chest wall recoil. Just I want to make it clear to you. Usually, when you want to push hard, providing high quality CPR, remember that your body will be in the top of the patient, right? Okay. By that way, you have to a little bit release your hand, not exactly keep leaning your body into the chest of the patient, because it will hinder the recoil of the chest. Minimizing interruption in chest compression, this is one of the other updates. The all rescuer should minimize the frequency and duration of interruption in chest compression. The same like the guideline in 2010. There is no changes. But here they added that adult cardiac arrest who receive CPR without an advanced airway, means still you are giving ventilation while you are performing CPR. There's a goal for chest compression fraction at least 60%. At least 60%, you are not interrupting CPR. And a goal 80% is often achievable with good teamwork. How to count this? How to calculate the 60%, 60 to 80? For us, in our instructor, we have to check. We have to really count using 2 stopwatches. The first stopwatch will run continuously when you start CPR till the end of the code. The second stopwatch, it will start and it will stop while the CPR started and stopped. You got it? Once the CPR and compression start, you press start. When it is stop, you press stop. For example, in 10 minutes code, the first stopwatch showing the result of 10 minutes, which is same with 600 seconds. And the second stopwatch will show 7 minutes and 30 seconds, which is 450 seconds. So that 450 seconds, you have to divide it by 600. So it will show you the result 0.75, which is 75 chest compression fraction. So we reached the goal or not? Yes, we reached the goal, right? From the 60% to 80%, at least 80%. The optimal number of chest compression fraction has not been defined. So still, if you can reach 100%, it will be much better. Actually, they intended this doing for the goal of chest compression to minimize the interruption. We have 2 types of interruption during compression. First, intended and unintended. The intended, such as while you are checking pulse, whenever you saw an organized rhythm. Second, while you are analyzing the rhythm. Third one, while you are checking the breathing, the previous one. And for unintended, we have like rescue something, maybe the rescuer suddenly fatigue, cannot continue, you have to exchange another one. This is one of the interaction. Ventilation during CPR with an advanced airway. Remember, once the patient on advanced airway already inserted ETT, how you're going to do? You keep pressing the chest, compress the chest, right? Without stopping. Not anymore 30 to 2. You keep compressing and the ventilation nurse will give oxygen, will provide the ventilation for how many? Every 6 to 8 seconds. This is in 2010 guidelines. So in 2015 guidelines, we are giving one breath every 6 seconds without 6 to 8. Okay? From 6 to 8 or 6 only? Only 6 seconds. Means you are providing 10 breaths per minute. Clear? It is easy for us to remember and to do it, to perform it. This is the BLS do's and don'ts of adult high quality CPR. As we know, once we reach high quality CPR, you have to do this 5 things, or you can call 4 things, because one is push hard and fast. When you say push hard, you push fast. When you say push fast, we have to perform chest compression at rate 100 to 120 per minute. When we say push hard, you have to reach the depth of 2 inches, but not more than 6 inches. Not inches, sorry. Centimeter. Thank you so much. And then you have to allow the full recoil after the compression. Minimize interruption, minimize pauses in the interruption and in compression, sorry. And ventilate the advanced 2 breaths after 30 compression, each breath deliver 1 second. So each second you can deliver 1 breath. As long as you can see the chest is raising, it's enough. Do not give an excessive ventilation. What will happen if excessive ventilation? Yeah, the intrathoracic pressure will be increased and the other will be decreased. So, what happened? Yes? You keep giving ventilation. What happened to the epigastric usually? Sometimes there will be gastric inflammation. What happened to the inflammation? Patient will be vomit. If patient is not conscious. So what probably will happen? Aspiration. So there is very dangerous effect if you are giving excessive ventilation. Now, bystander naloxone in opioid association, threatening emergency in adults. For patients with known or suspected opioid addiction who are unresponsive with no normal breathing protocol, it is reasonable for appropriately trained lay rescuer and BLS provider, in addition to providing standard BLS care, to administer intramuscular or intranasal naloxone. Everybody knows what is opioid, right? What is opioid? Yes. It's narcotic. No? Narcotic pain medication. Those who can treat moderate to severe pain that cannot be treated by another medication. That's the time you're using this medication. If you are not using it correctly, it will be giving you very side effects that's dangerous for our body. And nowadays, trend, some people using this thing not just for the treating pain, but for something to try, something to make it fun, right? Something to fly, they say. What kind of opioid? Anyone can try to mention to me what kind of opioid? What? Something with in at the end, right? Heptidine, morphine, heroin. What else? put in, right? Okay, so once you discover the patient arrest, either pulmonary arrest or cardiac arrest due to this opioid, this is what you have to do. This is the new latest algorithm, the build that. You have to assess and activate the same like you're doing BLS, and then begin CPR, of course, if you see there's no breathing or there is no pulse. Administer naloxone, which is 2 milligram intranasal, or 0.5 milligram
0.4.
if you are going to give intramuscular. Then you will check, does the person respond to the medication or not? If did not respond, you will continue CPR and use AED as soon as it's available. And if the person is responding to the medication, you can stimulate and easy. The additional is just you are providing naloxone, either through nasal or through intramuscular. This BLS interim adult skill testing form actually still not being distributed by American Heart Association. Still our training center using 2010 and 2015 guidelines, but this is just only for example for all of you, as you will be prepared once you are renewing your BCLS. The changes is in number 1, 2, and 3, the assessment sequence, the immediate recognition and activation of emergency response system, and then the assessment of breathing and pulse. The compression rate also changed from at least to 100 to
120.
100 to 120. Now let's talk about the basic life support and CPR code. There is no big changes, okay? No big different changes. The same like an adult. So the content, like immediate recognition and activation of emergency response system, the same. CAD sequence, chest compression rate, depth, and reaffirmation that compression and ventilation are needed for pediatric DLI. In the immediate recognition and activation of emergency response system, usually in USA, they have already application in their smartphone that they can use pulse point. Whenever you are discovering the patient arrest, if you are untrained, you can use that application that can teach you how to do CPR. Even they can find the AED nearest to you. But here in Kingdom, I tried, it's not available. In a continuous effort to minimize delay, the encouragement of simultaneous assessment and breathing and pulse, the same like in adults. The CPR sequence is unchanged, the same. For the one rescuer, begin with 30 compression followed by 2 breaths, and 2 rescuer begin with 15 compression followed by 2 breaths. First rescuer, 30 to 2. If 2 rescuer, 15 to 2. And the chest compression rate, the same in 2015 guideline, just like an adult, from at least 100 to 100 to 120. That is the changes. The same like an adult. For the depth, for the infant, approximately 1.5 inches. Okay, at least the third arterioposterior diameter of chest in pediatric patient. For the children, about 5 centimeters. At puberty, follow adult recommendation, and for adult, as we learned already, for how many centimeters? 5 to 6 centimeters. Provide chest compression, reaffirmation that compression and ventilation are needed for pediatric patients. Conventional CPR of chest compression and breath are best for pediatric patients, so we cannot forget ventilation during compression. It's very important. This is the example for BLS, pediatric intern for infant. On the same like an adult, they are showing only the changes. They highlighted. Up to now, is there any question? No question? Okay. If there is no any question, I have a little bit remembrance for you. It's not that very good thing, but you remember that you can answer my question. Okay, I have 5 questions only. The first question is, what are the elements of high quality CPR? I'm waiting for your chest, not chest raise, hand raise. Yes. What are the elements of high quality CPR?
No more fast and no more slow.
Yes, sorry.
No more fast, no more slow.
No more fast, no more slow for
CPR.
the compression. Okay. Yes.
If you want to check the depth, if it is accurate, you must hear the sound of it. If it is not, you cannot hear it.
Okay, so how many exactly? How many inches or how many centimeter exactly for the depth?
For a depth from 2 inches to 2.4 inches.
Very good. What next?
For media 1.5 inches to
No, for adult. Yeah, for adult only. What is the content of elements of high quality CPR? You already mentioned
The depth.
not too slow, not too fast. Means how many compression per minute?
100 to 120.
100 to 120. Very good, thank you. And you already mentioned that the depth is from 2 to 2.4 inches, which is 5 to 6 centimeters. So what are the other elements? Yes. Exactly, just recoil. What else?
Minimize.
Okay. Very good. One more. Yes. Ventilation. Good. Thank you so much. You're good, me, ma'am. Which department you're working? Which department you are working? Female medical ward and endoscopy. Thank you for 2%. I need you to just raise your hand and tell me where you're working. So it's okay, your good name and where you're working. Thank you so much. Second question. What are the latest highlight updates of American Heart Association 2015 BLS guidelines? Raise your hand, please. Raise your hand, not everyone talking. Yes? You don't want to go home? You're feeling ashamed or I'm sure that you know that, right? Yes?
Before we are taking any.
Can we give chance to another person?
From here.
Yes.
We have from here.
Yeah, please. Yes, sister, what's your good name? Which department you're working? Alia from? Female PSP. Okay, so what is the highlights? At least mention to me 3 things. Okay.
This assessment,
Very good. Yes, assessment.
this changes the compression,
Mm-hmm.
100 to 120,
Okay.
and this spread
Sorry?
to depth.
Okay, the depth. So you're mentioning for the assessment, recognition and activation, you mean, right?
Yes.
And then the compression rate and compression depth.
Depth.
Let us see, it's correct. Right? We have another one for shock first versus CPR first and ventilation during CPR with advanced air. Thank you, very good answer. Yes. Question number 3. What is the target goal of chest compression fraction? And what are the intended interruptions during CPR as part of required care? I didn't hear. I want to see. Who? Yes.
Yes,
Yes.
from IC.
60% chest compression fraction. Very good. And what are the intended interruptions? No, I mean when you can interrupt during compression. Sorry?
Can you sweat?
Sweep.
Okay. During switching, okay. means when you are asking them to switch. During.
Compression.
Very good. Reading means you are analyzing the rhythm. What else?
And pulse check.
Pulse check. Thank you for helping her. What else?
And
Yes. Correct. With 60% chest compression fraction. And then checking for pulse, providing ventilation. Remember, after 30 compression, you are giving ventilation for 2 seconds. Back. What are the intra-hospital cardiac arrest chain of survival? This is the latest update. The first update that is started between intra and outside hospital cardiac arrest.
side we have
From the back side. From the back side, please.
Yes, from ER. We have here.
Yes? What is the chain of survival?
first is assessment of responsive supervision.
Okay. Don't mix with outside. Now we are inside.
Chain.
The picture of the chain is assessment of responsive supervision.
Okay.
Then
Yes.
health and
Mhm.
assess for start compression.
Mhm. Very good. After that. Mhm. Somebody wants to help her?
Ask for help.
Okay.
Defibrillation.
Very good. Early defibrillation and CPR she mentioned already. Of course, after CPR you are doing providing early defibrillation. Then
Medical assistance and then hospital.
very good. Means post cardiac arrest care. Remember they are transferring to saturation lab or to ICU. But there is one additional before assessment, which is we have a team. Remember? The surveillance and prevention. This is the additional from American Health Association in intra-hospital. Because the patient already inside hospital. Okay? This is all our responsibility to prevent patient to arrest. Thank you, very good answer. Number 5. Explain the algorithm for opioid-associated life-threatening emergencies. Who can mention that? This is my last question.
We will give him 2.
Yes, naloxone, but how? Naloxone, I know also naloxone, but how? The algorithm from the first time. Yes, Shirin. Okay, from the beginning, Mom. From the beginning. From the beginning, what you will do?
Analyze the rhythm.
You found a patient with sign that he's having opioid overdose. Wait, let Miss Shirin to because
Where she is?
raise, yes, she's the one. She raised her hand.